High blood pressure is one of the most common reasons adults visit doctors in the United States. After all, 30% of adults in the US have a diagnosis of hypertension, with half of those patients not under adequate control. You'll see so many patients with a history of hypertension in your career that you might forget how serious it really is. In this sketch, we'll navigate the dangerous waters of this topic by exploring the levels of the RMS Titanic, which, as everyone in the post James Cameron world is aware, plunged to the floor of the Atlantic in 1912 with 2,229 souls on board. Just like that pesky iceberg was to the Titanic, hypertension is a major source of morbidity and mortality, silently waiting under the surface to take us down. So let's slow down and steer around those icebergs, people. At Sketchy, hypertension is depicted by a steaming, leaky pipe. In 2017, the ACC and AHA released updated guidelines on hypertension, including new definitions of the different stages of high blood pressure, as you can see. A pressure gauge attached to the leaking steam pipe represents the stages of hypertension. These guidelines define a normal blood pressure as a systolic blood pressure less than 120 millimeters of mercury and a diastolic less than 80. If your systolic BP is between 120 and 129, but diastolics are still less than 80, then you have quote unquote elevated blood pressure. The actual diagnosis of hypertension starts with a systolic blood pressure between 130 and 139, or a diastolic blood pressure between 80 and 89. This is defined as stage 1 hypertension. Systolic blood pressures greater than 140 or diastolics greater than 90 means you have stage 2 hypertension. A small point of clarification: if your patient's systolic and diastolic pressures put them in different stages, go with whichever is higher. Before we move on to the subjective findings in hypertension, let's touch on a few important topics like how to take a blood pressure, who to screen for hypertension, and the etiologies of hypertension. First of all, it's important to note that a single measurement of high blood pressure in the doctor's office does not mean the patient has hypertension. If someone has hypertension only in the office but not at home, they might have white coat hypertension, represented by this contemplative young intern, still wearing his new long white coat. If you suspect white coat hypertension, ask your patient to check their blood pressure at home, symbolized by his lonely yearning for his little home back in Ireland. If their BP measurements at home are normal, they might just have white coat hypertension. Follow up with 24-hour ambulatory blood pressure monitoring to evaluate their BPs when they are relaxed at home. Along these same lines, keep in mind that the diagnosis of hypertension requires multiple measurements of high blood pressure over time, whether at home or in the office. The exceptions to this rule, as there always are, include patients who present with a blood pressure of 160 over 100 or higher and have signs of end organ injury, or patients who present with severe asymptomatic hypertension, defined as 180 over 120 or higher. Check out our sketch on hypertensive emergencies for more on these emergent conditions. Because hypertension is so common, the USPSTF recommends screening all patients over 18 every year. That includes young Rose, who is secretly celebrating her 18th birthday behind a privacy screen with her forbidden sweetheart. Speaking of her handsome paramour, Jack represents a patient or someone with systolic BPs between 120 and 129, or risk factors for hypertension, which we'll get into in a moment. Patients like Jack should be screened every 6 months instead of 12. Just as important as who is the how, specifically how to measure blood pressure properly. First things first, make sure your patient hasn't had any stimulants recently. We're talking caffeine, nicotine, or cocaine. Hey, it's a legit concern. BPs should be measured with the patient comfortably seated, the arm at heart level, and an appropriately sized cuff. Too small a cuff will artificially increase the blood pressure measurement, while one that's too large will artificially lower the reading. Check the blood pressure in both arms initially, because differences between arms can suggest things like subclavian stenosis, peripheral arterial disease, or even aortic dissection. Most cases of hypertension are primary hypertension, formerly known as essential hypertension. Less commonly, you'll see secondary hypertension, which is hypertension due to an underlying medical condition. There are a bunch of causes of secondary hypertension, so let's quickly scan through the most important ones now. We'll get into more detail on each of these causes later. Renal artery stenosis is one of the most common. However, renal parenchymal disease of any kind can cause secondary hypertension too. This includes acute and chronic renal failure and polycystic kidney disease. Endocrine causes of secondary hypertension include primary aldosteronism, formerly known as hyperaldosteronism, represented by this mineral crystal chandelier. Cushing's syndrome, represented by this big red cushion and the moon-faced porthole. Pheochromocytoma, illustrated by the multichromatic rainbow shave ice with adrenal-shaped toppings. Thyroid disorders, including both hypo and hyperthyroidism. Hyperparathyroidism, and coarctation of the aorta. All that pathophys is nice, but let's get to the good stuff, the clinical presentation of hypertension. As we work through the subjective and objective findings you can expect to see, keep in mind that your goals during the H&P are to assess for any existing end organ injury, cardiovascular risk factors, and potentially modifiable lifestyle habits or medications that might be contributing to the patient's hypertension. You'll also want to be on the lookout for findings that can clue you in to a specific cause of secondary hypertension if that's what your patient has. One of the biggest issues with hypertension, also known as the silent killer, is that many patients are completely asymptomatic, just like this happy young man, a recurring sketchy symbol for the asymptomatic patient. He doesn't seem to notice the giant iceberg straight ahead. Because they don't have any symptoms, many patients with hypertension don't go to the doctor. And even once they are diagnosed, it's tough to convince someone who feels fine that their medications are vitally important. While the majority of patients are asymptomatic, symptoms can occur if the patient's blood pressure gets super high, typically above 180 over 90, especially if they don't normally live there. At those levels, patients may complain of symptoms like headaches, vision changes, and even chest pain or shortness of breath. We won't delve into that here. For more info on hypertensive emergency, check out part 3 of this series. Certain patient populations are at increased risk for hypertension, so make sure to be vigilant with high-risk patients. Being older, male, obese, and African American, like the ship's captain, are factors that increase the risk for hypertension. These are also all risk factors for cardiovascular disease, by the way. His obstructive sleep apnea, which is to blame for his sleeping behind the wheel, is yet another risk factor for hypertension. A family history of hypertension increases your personal risk as well. High sodium intake and alcohol use are a couple of the important lifestyle risk factors associated with hypertension. Ask about the patient's past medical history, as they may already have end organ damage from untreated hypertension. Some of the conditions to ask about include coronary artery disease, acute coronary syndrome, heart failure, stroke, and chronic kidney disease. Many medications are known to cause or worsen hypertension, which is why you should always get a complete home meds list. Some of the medications that can contribute to hypertension include oral contraceptives, represented by this pill pack shaped ship's wheel, nasal decongestants, systemic glucocorticoids, and NSAIDs. Recreational use of methamphetamine and cocaine, represented by this hot cup of cocoa, can also dramatically increase blood pressure, so don't forget to ask about them. Everyone should be asked about risk factors for primary hypertension. In addition, in certain patients, it's also important to investigate for evidence of secondary hypertension. Consider secondary hypertension when patients present at a young age, like their teens or 20s, represented by this rambunctious youth. Also consider secondary hypertension in older patients who suddenly present with new hypertension, like this old timer who was dreaming of New York. And in patients with formerly well controlled hypertension that acutely worsens, symbolized by the acutely ringing alarm clock. Make sure to think about secondary hypertension when patients present with hypertensive emergency or intractable hypertension that's unresponsive to multiple therapies. Speaking of secondary hypertension, let's take a deeper look at some of its most common etiologies, starting with one of the most common, renal artery stenosis. RAS has two main causes, atherosclerosis and fibromuscular dysplasia. Atherosclerotic disease occurs in older people who are at risk of atherosclerosis in general, so look for a history of coronary artery disease, peripheral arterial disease, or stroke. See all that fatty grease dripping on this older gentleman pulling on that red renal artery rope? Those represent the plaques of atherosclerotic disease. In young women under the age of 35, fibromuscular dysplasia is a more common cause of RAS. It's a non-atherosclerotic, non-inflammatory disease which leads to the narrowing of blood vessels. In addition to RAS, fibromuscular dysplasia can also cause neurological symptoms like headache, TIA, and stroke if the carotid and vertebral arteries are involved. Regardless of the cause, renal artery stenosis may present with recurrent episodes of flash pulmonary edema, which is why both of these rope pullers are wearing our recurring sketchy wet lung life vests. Next up, the super interesting but rare pheochromocytoma. In a patient with recurring episodes of severe hypertension, diaphoresis, and headaches, just like this diner's brain freeze, think about pheo. A patient complaining of new weight gain, menstrual abnormalities, and hirsutism might have Cushing's syndrome, depicted by this overweight woman sitting on our Cushing's cushion. You got a little something on your face there. Oh, all right, never mind. You got it. Let's move on to the objective findings you'll see in hypertension. As we move through the organ systems, we'll point out exam findings reflective of end organ damage from long-standing hypertension, as well as stuff you might see in different causes of secondary hypertension. Every patient with hypertension should have a fundoscopic exam to assess for hypertensive retinopathy. Findings include flame hemorrhages, arteriovenous nicking from swollen arterioles that compress crossing venules, and cotton wool spots. These findings are represented by this flaming searchlight with its crossed red and blue wires, and that piece of cotton wool this repair guy's using to clean the outside of the light. Priorities? After you're done looking at the eyes, bust out that stethoscope. Listen to the heart for an S4 gallop, which can suggest left ventricular hypertrophy, a sequela of long-standing hypertension. Left ventricular hypertrophy is represented by this chief officer's large left epaulet, the fancy fringy shoulder thingy. Speaking of murmurs, that brings us to our next cause of secondary hypertension, coarctation of the aorta. You might have heard of coarctation of the aorta in peds, and true, while they're typically picked up early in life, non-critical coarcts can often go undiagnosed until adulthood. In addition to a systolic murmur heard over the narrowed part of the aorta, noted here by our recurring sketchy murmur lines emanating from the narrowed section of the big red pipe, when coarctation is found in adulthood, hypertension is typically the presenting symptom. Specifically, you'll find elevated BPs proximal to the coarctation, represented by this gauge showing high pressures proximal to the narrowed pipe, while BPs will be low distal to the coarct. Typically, you'll notice the difference when you compare the right arm BP to pressures measured in the lower extremities. Correspondingly, a delay between detection of the brachial and femoral pulses is another classic finding in significant coarctation of the aorta. In patients with hypertension due to renal artery stenosis, you may hear an abdominal bruit, illustrated by this noisy pipe with two little renal artery pipes branching off of it, right next to our renal artery stenosis rope pullers. Once you've listened to the belly, it's time to squish it. Palpating for abdominal masses is important because if you find bilateral upper abdominal masses, your patient just might have autosomal dominant polycystic kidney disease, a rare but important cause of secondary hypertension. At Sketchy, polycystic kidney disease is represented by these kidney-shaped bunches of balloons tied to that cracked kidney pulley. If you find truncal obesity, moon phases, proximal muscle weakness, and abdominal striae, think about Cushing syndrome and this fancy cushion lady. Her truncal obesity and weak, thin arms are making it tough for her to stand up. Notice how the curtains behind her look like abdominal striae? Even after the diagnosis of hypertension is made, you aren't done gathering data yet. Your next step is to look for end organ injury and the presence of comorbid conditions, which will guide your management of the patient. Let's take a look at this fancy spread here on the upper deck to review some of the labs you should order for every patient with hypertension. When a patient has hypertension, it's important to assess their overall risk for cardiovascular complications. And the first step in that risk assessment is to look for other diseases that affect their cardiovascular risk. Two biggies to screen for include diabetes by ordering a hemoglobin A1C, represented by this piece of sweet blue candy, and hyperlipidemia, with a fasting lipid panel, represented by this fatty, cheesy plate of pasta. In addition, a basic metabolic panel, represented by this metabolic dinner tray, serum calcium level, illustrated by the recurring sketchy calcium bucket of ice cream, and TSH, symbolized by the waiter's TS haberdasher bow tie, are recommended for all hypertensive patients. In addition to the BUN and creatinine in your basic metabolic panel, order a urinalysis to assess for kidney disease, which can be a complication of long-standing hypertension or a cause of secondary hypertension. Next, order an ECG to assess for left ventricular hypertrophy or prior MI, both of which can be cardiac complications of long-standing hypertension. Let's move on to the findings we can expect to see in conditions that cause secondary hypertension. Remember this cracked kidney pulley? It represents parenchymal kidney disease causing secondary hypertension. Well, the BUN bun bag and credit card being hoisted into the air are there to remind you that elevated BUN and creatinine levels can be a clue that kidney disease is causing your patient's hypertension. If you suspect renal parenchymal disease, such as polycystic kidney disease, as the cause of secondary hypertension, your next step should be to order a renal ultrasound, represented by this bullhorn blasting its sound waves at those kidney-shaped bunches of balloons. Next up, let's take a look at renal artery stenosis. In patients with RAS, poor perfusion to the kidneys causes activation of the renin-angiotensin-aldosterone system. Both aldosterone, represented by these mineralocorticoid crystals on the ceiling, and renin, represented by this yellow umbrella held high in the air, are elevated. Get it? Renin, umbrella. Works for me. In this way, renal artery disease is a cause of secondary hyperaldosteronism, in which elevated renin leads to elevated aldosterone levels. Therefore, both plasma aldosterone and plasma renin activity will be elevated, leading to a normal aldosterone to renin ratio. Contrast this with primary aldosteronism, in which aldosterone is high but renin activity is super low, leading to an elevated aldosterone to renin ratio. To confirm the diagnosis of renal artery stenosis, order a Doppler ultrasound, MR angiogram, or CT angiogram to look at the renal arteries. Hence our recurring sketchy black CT cat with its contrasty yin-yang collar, reminding you that imaging is the next step once you're confident your patient has renal artery stenosis. Okay, as promised, let's slip on over to primary aldosteronism as a cause of secondary hypertension. Primary aldosteronism is an adrenal issue, most commonly caused by either bilateral adrenal hyperplasia or an aldosterone secreting adrenal adenoma. The important labs for hyperaldosteronism are sodium, potassium, and bicarbonate. That's because, in addition to refractory hypertension, patients with aldosterone excess can have hypernatremia, hypokalemia, represented by this banana peel lying low on the floor, and metabolic alkalosis, represented by this bottle of basic cleaning solution held high up in the air as that lady slips on the banana. As we mentioned before, in primary aldosteronism, serum aldosterone levels will be super high, just like this mineral crystal chandelier, while plasma renin activity will be super low due to negative feedback inhibition. Hence, this yellow renin umbrella being dropped by our soon-to-be fiancé. This results in an elevated aldosterone to renin ratio, typically greater than 20, kind of like the 20 on the ring that this hopeful young man is proposing with. It's no heart of the ocean, but hey, whatever works. Moving further down the secondary deck, let's look at our next cause of secondary hypertension, Cushing's syndrome. If you suspect Cushing's syndrome in your patient based on the history and physical exam, confirm the diagnosis with the dexamethasone suppression test, represented by this dessert index, 24-hour urine-free cortisol, and or late-night salivary cortisol levels. For more details on the diagnosis of Cushing's syndrome, check out our sketch dedicated to it in the endocrinology unit. Fortunately, Cushing's syndrome typically presents with many other identifying features. With pheochromocytoma, you might not be as lucky. If pheochromocytoma is suspected, make the diagnosis by ordering 24-hour urine metanephrines, represented by this metanephrine mint leaf on that pile of yellow ice cream. Bet you'll never look at ice cream the same way again. Moving on to other endocrine causes of secondary hypertension. As we mentioned earlier, thyroid disease should be ruled out in all hypertensive patients, even if they're asymptomatic. A TSH, represented by this box of TS haberdashers bow ties, is the preferred initial test. While you're at it, take a look at the calcium too. An elevated calcium level, represented by this carton of calcium ice cream held high in the air, may suggest hyperparathyroidism as the cause of secondary hypertension. Finally, let's circle back to coarctation of the aorta. If a coarct is suspected, start by ordering a routine chest x-ray to look for inferior rib notching, represented by this ladder with bent rungs. These little inferior divots in the ribs result from dilated intercostal collateral vessels that form to bypass the coarctation and supply the descending aorta. Then confirm the diagnosis of aortic coarctation with a transthoracic echo, represented by a recurring sketchy symbol, the heart-shaped megaphone. All right, let's summarize the presentation of primary hypertension with a sample assessment statement. We'll focus on primary hypertension here, since the presentation of many of the causes of secondary hypertension will be covered in their own respective sketches. Wallace Hartley is a 54-year-old man who presents to establish care. He has no complaints, no significant past medical history, and does not take any medications. Family history is significant only for hypertension on his mother's side. Vital signs are significant for a blood pressure of 154/92 and a BMI of 28. His physical exam is otherwise unremarkable. Routine labs, including BMP, creatinine, calcium, TSH, and fasting lipid profile, are unremarkable. His ECG is significant for left ventricular hypertrophy. Based on these findings and his initial workup, Mr. Hartley most likely has chronic stage 2 primary hypertension. Awesome! Let's wrap up this sketch with a brief review of what we've learned. Hypertension is a clinical diagnosis that can be broken up into 4 stages. Normal blood pressure, defined as a systolic BP less than 120 millimeters of mercury and a diastolic BP less than 80. Elevated BP, defined as systolics between 120 and 129 and diastolics less than 80. Stage 1 hypertension, defined as systolics between 130 and 139 or diastolics between 80 and 89. And stage 2 hypertension, defined as systolics greater than 140 or diastolics greater than 90. The causes of hypertension can be broken up into primary hypertension, formerly known as essential hypertension, in which no other condition is to blame, and secondary hypertension, which is secondary to some other condition, such as medication side effects, renal artery stenosis, renal parenchymal disease, primary aldosteronism, Cushing's syndrome, pheochromocytoma, thyroid disease, parathyroid disease, and coarctation of the aorta. The vast majority of patients with primary hypertension won't have any symptoms, which is why routine screening is recommended for every adult every year. Even if your patient feels just fine, certain risk factors should raise your concern for primary hypertension, including older age, obesity, African American ethnicity, obstructive sleep apnea, family history of hypertension, excessive sodium intake, and excessive alcohol use. On the other hand, in younger patients with hypertension, older patients with new onset hypertension, or patients with pre existing hypertension that acutely worsens, your thoughts should turn to secondary hypertension. Fortunately, the conditions that cause secondary hypertension tend to present with other symptoms and signs, such as an abdominal bruit in renal artery stenosis, bilateral abdominal masses in polycystic kidney disease, headaches and diaphoresis in pheochromocytoma, moon phases, truncal obesity, buffalo hump, proximal muscle weakness, and abdominal striae in Cushing's syndrome, and a BP discrepancy between the upper and lower extremities with brachial femoral pulse delay in aortic coarctation. Once you've found hypertension in your patient, start looking for the complications of chronically high blood pressure, including hypertensive retinopathy, left ventricular hypertrophy, and hypertensive kidney disease. Then assess for additional risk factors for atherosclerotic cardiovascular disease, including diabetes, hyperlipidemia, and prior MIs. This will help guide your management of the patient moving forward. Speaking of which, that's a wrap for us. It's time to move on to management. Check out the next sketch in this series for all the details on what to do for your patient.